Hi, this is Brian Kim. I'm going to share with you this case of a patient with one of the worst ultraluminescent cataracts that I've done. This patient also has a small pupil, and so you'll see I'll be placing iris hooks and using trypan blue. And I'll be doing the terminal chop technique as well as cross chops and scissoring chops. Again, all of this is to help deal with that really full density cataract, which means when you're trying to break through, it's very difficult to separate the lens pieces because of the leathery adhesions. And so you'll see how I manage this in this really, really tough case. And so I'm making my incisions, which include for the iris hooks. I like to place 5 iris hooks, 4 on the limbus, and then 1 in the subincisional episclera. So go ahead and inject some intracameral lidocaine and then some epinephrine. And then before placing the viscoelastic, I like to place the hooks. If you place the viscoelastic in first, it can cause the iris to get pushed back, and it just makes it more difficult to place the iris hook. So I start with the subincisional episcleral hook here, and then I'm going to place the other ones as well. I had some trouble getting it around the iris, and so I go ahead and place the one adjacent to it in the cornea first, which helps to elevate the iris. And then now I'm placing the subincisional hook now. So that's another tip. If you're having some trouble with the access, try a different hook. And then once you hook it, you're able to lift the iris with the hook. Go ahead and place the remainder of the hooks. And again, the iris hook issue, some people have trouble with them. It's really not that difficult. You want to just pull the stopper back and then just rotate the tip of the hook so it's pointed down. And then this is the last hook. Pull the stopper back, turn the hook downward, and then cinch it down. This is some intracameral trypan blue after putting some air in the eye. And I'm gently dripping the trypan on the anterior capsule surface, and I'm not overinflating the eye when I do this, minimizing any potential dye going into the posterior segment. And this is some dispersive viscoelastic to push out the air bubble as well as the dye. So this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I get a nice shelf, I enter. Push some more viscoelastic in. And these are the Haldi-Perkar forceps. Not quite sure if I'll be able to puncture with these, but I'm giving it a try. Probably not. So I go ahead and switch to a cystotome. I'm puncturing. Pulling towards the left, pulling down to create a little bit of a flap. Switching to the Haldi-Perkar forceps. Going around circumferentially, making sure that the rexus size and centration matches the corneal mark I made previously. Okay, the rexus is finished. And this is a capsular fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. You can see the lens is rather wobbly. That's one thing I noticed there. Go under, turn the tip down, get a nice wave, gently decompress, sweeping on the left side and pushing BSS as I do this, and then carefully sweeping on the right side, and you can see as I start to spin the lens, it's able to move fairly briskly there. So I have a loose lens, I have a dense cataract. At this point, I can't really appreciate how dense it is, but I will soon. I retract the sleeve quite a bit. Removing some surface epinuclear material, and then I go ahead and start sculpting. I'm sculpting a central trough. And as I do this, I see how the lens behaves and see if the lens is moving a lot. Is it due to weak zonules? Is it because the lens is so dense? So I actually switched to the dense cataract mode here. So this is in sculpt mode. Again, I'm sculpting, but you can see this is rather dense. So instead, what I do is I place the chopper around the rexus edge contra-incisionally, and this really helps me sculpt much more efficiently. Since I have that counterforce, it almost creates like a wedge so that I'm able to sculpt deeper and more efficiently rather than just scoring the top. And once I feel good about my trough, this is that terminal chop technique. I was able to fracture the lens from the periphery and fracturing it from the terminal side of the lens, which provides a much deeper chop, which propagates all the way through and prevents that posterior plate effect. So now that the lens is completely bisected in half, I place a chopper around that first heminucleus with that phaco tip deep. I go ahead and fracture that in half. You know this is the dense lens because it's not just white, it's not just yellow, it's kind of like a reddish brown color. And so when you saw that reddish brown color, that's a sign that this is really a really dense cataract here. So again, I'm doing that mechanical fracturing technique, cross chops, and using crushing forces to break the pieces into smaller pieces. And then once they're smaller, go ahead and emulsify those pieces out. Using a little bit of vacuum to lift that piece up, crushing the lens between the instruments, using some more vacuum to position the lens piece, and then crushing it into smaller pieces. Crushing again between the instruments. And you know, sometimes it takes a lot of effort because even though you're cracking and crushing, sometimes the pieces still don't want to separate. And it's, again, that's a testament to how dense these lenses are. Typically, you divide the lens and it just splits apart, and then you go ahead and keep eating the pieces. Not with this lens. So you can see the CDE is already around 12, and again, most of that occurred during the sculpting part of the case. Again, I'm placing the chopper underneath the rexus edge, bringing that piece up. It kind of was stubborn there. So using some vacuum to hold it, and then getting around it with the chopper, and then crushing the lens piece in half by sandwiching it and crushing it between the instruments. And you can see as the lens pieces come up, they're shiny. They're like almost like shards of glass. They're just so dense. So now I'm rotating the second heminucleus in front of me, placing the chopper around the lens piece, placing the phaco tip deep, getting a fairly deep chop, making sure I'm separating the lens pieces completely, placing the chopper around that quadrant there, hooking the peripheral lens up, and then crushing the lens between the instruments, grabbing that one piece up with some vacuum, and then crushing the lens between the instruments. So again, by crushing the lens pieces between the instruments, I'm not having to use any ultrasonic energy or vacuum. I'm able to do that right in the middle, crushing the lens pieces. And once they're small enough, I can use pulses of vacuum as well as ultrasonic energy to remove the lens pieces. And so this is like, in my way of thinking, this is a phaco or ultrasound sparing technique. So I'm just removing some of those small fragments as I've chopped them into many small pieces. And if there's occlusion, I just crush the lens piece between the instruments and then emulsify the lens pieces. It's amazing how dense this lens is. You're chipping away, removing the pieces, but it almost feels like you're not making any headway here. Finally, you see some daylight. You can actually see a red reflex now. So using some vacuum again to grab these small pieces, crushing the lens between the instruments and then emulsifying the lens pieces. At this point, I have a quadrant left. I want to protect the cornea. And so I push some more dispersive viscoelastic to protect the cornea. Rotating the lens so it's in the right orientation, getting around the lens with the chopper, placing the phaco tip deep, trying to get a hold of the lens, getting around the girth of the lens, and then I'm able to crush it between the two instruments. Doing the same thing, getting around the lens piece, crushing the lens between the instruments. And if you can't get around it, you just try again, use a little vacuum, hold the lens piece and getting around it with the chopper, hooking the lens, and then crushing the lens again. So here I'm just crushing, and right here I'm trying to crush the adhesion that's keeping the two pieces up. So that's the scissoring chop maneuver right there, turning the chopper sideways and amputating the adhesion. To me, this is a very effective way to get rid of that adhesion rather than just using ultrasonic energy and just gobbling up the piece. Get to the source, amputating that adhesion with that scissoring chop maneuver. So again, I'm just crushing the lens pieces between the instruments until they're small enough with successive crushing maneuvers, and then emulsify the lens piece. So again, you see I'm just keeping the chamber stable and formed and just positioning the instruments around the lens pieces and then crushing it, rather than going after it with high vacuum. And if you go with high vacuum, you can grab the posterior capsule and cause a rupture. And so I'm being very gentle and mindful of that. Using some vacuum to grab the pieces and then crushing the lens between the instruments over and over again. Again, these pieces are so dense, even though I crush them, they don't want to split into pieces and they don't want to separate. Again, because of that leathery consistency of the dense lens. So at this point, there's only a small few fragments left. Rather than going after them with vacuum, I decided, okay, I don't want to do that and actually grab the posterior capsule. So I go ahead and take the chopper out and I'm going to push dispersive viscoelastic into the bag and to coat the cornea. And what that does is it keeps the posterior capsule back. That dispersive viscoelastic likes to stay put as long as you don't go after it. So I'm going to use the chopper to lift that nugget. That's like a rock nugget, a marble. I'm lifting it up and then getting around it with the two instruments, and then I'm going to crush it. Like I said here, this is such a dense nugget here. Crushing the lens between the instruments. Keep crushing, keep crushing, keep crushing. You saw there I actually crushed that lens piece with the chopper against the side of the phaco tip. Again, this is just mechanical forces. There's nothing magical about it. But the beauty of this machine is this provides exquisite inter-chamber control and a full fill. So as I eat these pieces, I'm being mindful, making sure the posterior capsule doesn't come up, because the posterior capsule will. There's nothing else protecting me from the posterior capsule. So very carefully making sure I don't get some type of occlusion surge or anything like that. Take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. I switch to cortex mode, but I see a nugget right there to the right. And the nugget just follows as I do that real quickly. So two rock nuggets. They were barely on the tip, and so I figured it was just easy enough just to come out of the eye and the lens pieces would come out. I'm having to use a cannula to crush that small nugget. You can see that wouldn't even aspirate through the port. So I start sub-incisionally removing the cortex, sweeping side to side, which is very helpful in the context of weak zonules. And again, with these dense lenses, I always assume there's some level of weakness to the zonules. I switch to polish mode, polishing underneath the rexus edge of the lens epithelial cells. Switching to cortex mode as necessary, but using foot pedal modulation to control how much vacuum I use. I don't want to use too much vacuum and actually grab the capsular bag, which can stretch the zonules. I'm going to pulse some BSS into subincisional capsular fornix. You have to be careful when you do this maneuver. It just takes a little bit of care. Pushing cohesive viscoelastic to fill the capsular bag, and this is the sweep. Again, this is the original sweeper that I was using. I no longer use a sweeper. Polishing underneath the rexus edge of the lens epithelial cells. This will be a 3-piece lens. I'm going to widen the incision a little bit as necessary to accommodate the cartridge. Place the barrel into the eye. Have the bevel facing to the left. The leading haptic comes out, planar underneath the rexus edge. As the optic comes out, you want to rotate your wrist counterclockwise about 90 degrees. The trailing haptic comes out appropriately, pointed to the right, and then I'm dialing the trailing haptic in. But look what I do. I inadvertently did not place the trailing haptic within the bag. It's actually in the sulcus. So I'm trying to figure out how am I going to get that back in. So here I ask for a Sinskey hook, and I'm trying to pull the haptic centrally, but as I do that, you can see the lens starts to rotate. And so when I apply that force on the haptic towards the center, it slips, and then the lens started to rotate. And so I'm thinking that's probably not the best instrument. So I'm using micro forceps to grab the haptic. And as I do this, I'm able to tuck the haptic into the bag, and now we're in good shape. So yeah, sometimes those things happen, but thankfully that was kind of a fairly easy and elegant way to deal with that. since that haptic did not go into the bag and went into the sulcus, that was a fairly easy way using the microforceps to grab the haptic and gently place it into the bag. So I'm taking the hooks out now. You can see I pull the stopper back, and then as I try to pull the hook up, I try to rotate the hook so that the end of it doesn't get broken off. There you go. So by doing it this way and being gentle on the hook, we can reuse these hooks. I go in with the INA handpiece, activate the irrigation, removing the viscoelastic from the anterior chamber. So I carefully decompress the chamber. I come out with the INA handpiece. I push BSS through the paracentesis incision to keep the chamber formed. And then I go ahead and hydrate my incision. So again, this is an ultraluminescent cataract, one of the worst cataracts. I had to perform terminal chop, cross chop, scissoring chop. And the cataract was not just white or yellow or brown, it was actually red. Very dense lens. I was able to place the chopper around the lens itself to support it as I did a more aggressive sculpt. Because if you don't have that counterforce when you're sculpting, all you'll end up doing is pushing down on the lens, and all you're doing is just stretching the zonules and causing problems. And so that's obviously not good. And so by placing the chopper around the lens, I was able to provide that counterforce and perform a more efficient sculpt. And then I placed the chopper around the lens and perform that terminal chop, which ensures that you don't end up with a posterior plate. I was able to fracture the lens pieces with crushing forces, utilizing sparing amounts of ultrasonic energy and vacuum, crushing the lens pieces into smaller pieces. And whenever there was an adhesion between the lens pieces, I was able to turn the chopper sideways and perform the scissoring chop, amputating the adhesions, and then crushing the lens pieces into smaller pieces, and then emulsifying the lens pieces. By doing it this way, I do feel like this is better for the cornea. You'll have clearer corneas postoperatively, less ultrasonic energy use, and overall a safer and more systematic disassembly of the lens. So I hope this was helpful to you, and I thank you for your attention.